Shut up and sit down.
This is Holistic Vigilantes, hosted by Dr. Kimberly Bear and Dr. Jennifer Tippegraph. These two badass dentists are breaking the mold to provide modern dentistry that doesn't compromise overall health. Determined to spread the word, the Vigilantes are kicking down the door as they bring you honest answers to hard questions. Buckle up for a wild ride down the Meridian Highway as they explore the connection between oral health and whole body health, saving the world one smile at a time. And now, the Holistic Vigilantes.
Hello, my name is Dr. Jennifer Tippegraph.
And I'm Kimberly Bear.
And we are the
Holistic Vigilantes.
Today here we have Miss Hallie Bulkin. I'm very excited to have her. Hallie and I actually grew up together. Go way back, like kindergarten, first grade. Mm-hmm. Grew up in the same neighborhood, Stonebridge, off of Travilla Road. Very, very cool. It's like sitting here, I'm having this moment that's just like,
come full circle, right?
Yeah. It's awesome. Hallie's always been an entrepreneur from super young. I mean, you were helping plan parties.
Back in like high school. Yeah.
Doing some of the like nutritional supplement stuff, all that Beachbody.
My salad. Oh yeah, network marketing. And then I finally went, nah, let's do something else.
But you definitely have come just such a long way, and it's awesome. You have your master's in speech language pathology from University of Maryland. You specialize in orofacial myology, pediatric motor, speech, and feeding issues. And it's just so incredible because I've seen firsthand what you do. And when my son was having some issues with feeding, you were like, I got this, no problem. And I'm like, oh my gosh, my son came over, did an evaluation, and I was so appreciative. And you definitely know your stuff, and it's so cool. And you are the creator of many businesses, and you are the founder of the Untethered podcast, which has over like 115 episodes now.
Yeah, it's something around there. I had lost count.
I remember when you first started, I was like, I think I was number 5. You were, I think, 50 or 45.
Yeah,
it was it's awesome, and it's so informative. So for other listeners out there, the Untethered podcast is definitely something you should listen to. So welcome to the Holistic Vigilantes.
Yeah, welcome. Thank you. I'm excited to be here. So, and just to clarify, Hallie's a myofunctional therapist and has a business where she basically trains and oversees many therapists. So she's she's definitely what you would consider a, what is the word I'm looking for? Pioneer. Yeah. Yeah. That's a good one.
Leader.
Yeah.
Educator.
An expert. Thank you. Yeah. But so Hallie, why don't, so a lot of people don't even know what a myofunctional therapist is and how they would maybe differ from being just a speech therapist.
Sure. Yeah. So what's interesting to know about myofunctional therapy is that speech language pathologists have it in their licensure, their certification. It's part of what we do, but most graduate programs don't actually train you in it. So technically, if you look at our scope of practice, it's listed there, but most people are like, I couldn't tell you what this is. And so I'll give an example, and then I'll talk a little bit more about what myofunctional therapy actually is. But working with little kids who had speech sound disorders, hard to understand, mixing up sounds, just not producing certain sounds. I used to look at them completely different before I took my myofunctional therapy course because I was trained to look at the anatomy and physiology and how things are being produced and working. But as long as it sounded okay to the ear, it didn't matter if they were putting their tongue in the right place or their mouth or their face or, all the orofacial structures. It didn't really matter what they looked like for all intents and purposes, as long as we understood what they were saying. That was pretty much the standard. And then I took my myo course and learned I took a deeper dive into the orofacial structures and learned that it really does matter where we put our tongue for both speech and swallowing. And so myofunctional therapists are really looking at where does the tongue exist in the mouth? At rest. So when we're not speaking, we're not eating, just sitting and watching TV or playing a sport, when we're not using our mouth, our tongue should be up in the palate. Our lips should be closed. We should be breathing through our nose. And
as everybody starts to do that right now.
Exactly, right? Everyone's going, oh, where's my tongue?
I know. Yeah.
What are my lips doing? And so we start to look at that, but then we also look at, from a speech standpoint, speech pathologists in particular, we'll look at where are they placing their tongue to make certain sounds? Where are they putting their tongue to swallow? Where are they putting their tongue when they chew food and move it? Are they moving it around their mouth, or is it just staying in one place? And so we start to take a deeper dive into the orofacial structures and actually where they exist. Are they functioning properly? Because this goes on to impact much more beyond speech and swallowing. There's a full body impact when it comes to our tongue rests in our mouth. So
it's sort of like teeth, like, you know, you'll have people that like will just line up all the teeth and it will look pretty,
yes,
you know, but then it's like, how is this person functioning? What
that was me.
Joints? Yeah. What
that was me as a teen.
Like?
Yeah.
And so it's like the tongue could look pretty, but is it functioning?
Mm-hmm.
Yeah. Yeah. In school.
Or the speech could sound pretty.
Right. Exactly.
What were you saying in school?
Nothing.
Well, no, and I was that patient that you mentioned. So we get a lot of teens that have had, or adults that have had orthodontic relapse because they had a rapid palatal expander, which maybe opened their airway a little bit and made their palate a bit wider, but we know that only expands in one dimension. And we need to usually grow the palate forward, which I know is your expertise. So I defer to you on that front. But what happens when we do that is we open the airway so that we actually can breathe through our nose, and we give the tongue more space to rest in the palate. And so now we can actually achieve that tongue up, lips closed, breathe through the nose posture that myofunctional therapy addresses. So
when someone's a myofunctional therapist, like will they look at speech too when they're doing their tongue position?
So speech pathologists, yeah. Okay. Yeah, SLPs, speech pathologists will look at speech. Registered dental hygienists, so traditionally, SLPs and registered dental hygienists and dentists were who were initially trained in myofunctional therapy, and now other organizations have gone on to include other professions. So I've been a big advocate, for example, for occupational therapists to do myo because they do feeding therapy, and so you don't necessarily have to be a speech pro or a speech pathologist to assess and treat myo, but the speech would then be separate, and you just would refer to an SLP afterwards if the speech sounds don't correct themselves. Because I'll tell you, in like half my cases, I never have to address the speech full on. When you teach that tongue where it should be, oftentimes they stop thrusting the tongue forward, or the tongue now, if we release a tongue and we do the pre and post-op therapy in myo, that tongue can retract fully, and it's not doing this like, so what will happen is it kind of will retract and go to a strange part of the palate instead of going back to where it should be for like certain sounds that happen in the back of our mouth. So, so we have speech pathologists who sometimes only treat speech, and we really try to get them to put their myo eyes on, as we call it. And then we do get parents who say, look, my child's really struggling with these sounds, and we'll address them from day one because we can, but we prefer to like get partway through the myo program to see what kind of gets cleaned up first before addressing it.
Yeah. So, Jennifer, you wanted to talk about tongue ties?
Sure. Yeah. So would you say that now knowing what you know and seeing the bigger picture, would you say someone should start with the myo assessment before like the traditional like speech assessment, or?
So we do that in because we are speech pathologists, we do a myofunctional assessment that includes a speech assessment. Okay. If we feel like a child needs a full-blown speech eval, we can do that. That can take 20 minutes. Okay. So, we can do that during the myo eval if necessary.
So I'm just trying to, like, for our listeners.
Yeah. So, I mean, in that case, like if you have a child who has like a lisp and they can't make their R's and they've been in 7 years of speech therapy, you may want an SLP who does myo because you're going to have to address those speech sounds versus someone who maybe thrusts their tongue when swallowing and their speech sounds perfectly fine. You can go to an SLP, an RDH, an OT, any of these, a DDS, anybody who does myo that's qualified to do myo, sure. Or just look into linking up with an SLP to address the speech sounds afterwards if that's not possible.
Sure.
How many children that see or get speech therapy, especially I have a lot of patients who get it at school, when they're at school. How many of them would you say are tongue-tied?
I have no idea. No clue. But, I feel like there's this uptick in ties. And I talk about this in one of my courses. I think that it's epigenetics at play majorly. I think that there is a major misdiagnosis, but also undiagnosis. So I feel like a lot of kids are going undiagnosed because, one, the difference between speech therapy in the schools and speech therapy, what we do, we're medical based and they're school based, they're academic based. And so what the school systems say is, well, this is medically based and we can't do that. So they actually draw this line in the sand, which is completely ridiculous. And this is why I only worked in the schools for 3 years and I quit when my contract ended, because I was like, you can't tell me what's in my scope or what's not in my scope. This is completely unethical. Like, I know these kids need more, and they don't let you refer out, because if you refer out, then the family can sue and basically say the county's on the hook for paying for the services. So there's this whole bureaucratic BS that goes on in the schools. Yeah. So if you're a parent listening who has a child who gets services in the schools, listen carefully. Yeah. I used to sit across the table on the other side. I know how they train the SLPs in the schools here, especially locally.
How long should someone get, like, what is, for a child, a reasonable amount of time for speech therapy and for it to actually, you just see a lot of progress? I mean, they shouldn't be in speech therapy for years.
No. So I'll give you a really great example. I had this 13-year-old come to me who was starting high school, and mom said, I really want him to be able to produce his R's by September. And this was like March. And I was like, okay. I hadn't met him. I didn't know anything about him. We've had 7 SLPs prior to you. So this poor kid sits down in front of me. I whip out like this speech app just because I didn't want to give him a full-blown eval. I just wanted to like test a couple sounds. So I pull out this kind of like younger speech app, and he's like, does every SLP use that? And I was like, okay, putting this away. I was like, let's try something else. I mean, this poor kid, I swear. So he went and he had a severe tongue tie. Like, I don't know how 7 other speech pathologists in this area did not diagnose. They must not have ever looked inside his mouth. And that's honestly what happens. People are not doing intraoral evals. They're just writing down like oral motor skills within normal limits, like WNL. And I'm going, based on what? This kid was, so he had this interesting posture where he pushed his mandible to the side, and he had this like, it was like deviated at all times at rest, because that was more comfortable for him at the time. And I was thinking like, what is this doing to your TMJ? Like, this is awful. And then he would sit there and like kind of do this little grinding thing back and forth. And I was like, oh my gosh. And when I looked under his tongue, I sent him to the oral surgeon for a release, and he said that was a really complex release. He had a lot of extra skin under his tongue. Like, this kid was sutured up. But I will tell you, from start to finish, he graduated from Myo in speech in about 6 months. And he had been in 11 years of speech therapy prior to seeing me.
11 years.
11 years. And this is what kills me. Like, 7 speech pathologists. Parents are paying out of pocket for a lot of these services. And these kids are just bouncing from one to the next, to the next, to the next, because it's not working. And what people don't realize is we need to be looking in the mouth. We need to look at the tongue. We need to do more than just kind of tongue move side to side, in and out. We need to see like what's going on under the tongue.
Yeah. So once again, no one's asking the question, why?
No. Yes.
Not, let's treat the symptoms. Why is this happening? And at what point? I mean, he's lucky he saw you. Can you imagine if he didn't?
Yeah, it was incredible. And they worked hard, and he's doing fantastic, thankfully. But I see these kinds of cases all the time. And I will tell you, I've had men in their 30s crying in my office because they're like, basically everyone thinks that I'm clinically insane. And I'm like, no, you sound like you have severe obstructive sleep apnea and your body's afraid to go to sleep, like, which basically snowballs into 75 other symptoms and major issues for you. So no, you're not insane. And I mean, literally in tears, because like, you're the first person who's ever told me that. And I've been to these 17 other providers just this year alone. And I'm going like, holy cow, how has nobody picked up?
And they're probably being treated for all kinds of disorders that they don't even have.
They're like, oh, you have PTSD from this, or oh, you have PTSD from providers not providing you with accurate medical information, and your issues snowballing into bigger problems. I mean, it's a real problem.
For sure. And then these kids who have speech issues or tongue-tied, I mean, like airway, like the connection is, I mean, I don't know how they go. I don't even know if you can separate them.
No, you totally can't separate it. I mean, and so we actually just did like an infant sleep week recently on my Instagram account. And we did, where we just did some informational posts, because while I've created my podcast and my like Instagram account and my courses for professionals, I now have a ton of parents who follow me, and these moms who, I mean, I get DM'd at least daily asking for a referral somewhere else mostly in the US. And so I've started to create a directory of my graduates, because I want to be able to refer to people who I know have at least some training or knowledge of what to look for. And if they can't assess or treat it, they can at least know who to refer to in their area beyond them. So it's kind of become this big passion project of mine of getting parents, especially of infants, connected so that this does not like become a bigger issue. Like, let's address it at birth. Let's address it in the first year so we can hopefully mitigate and, or eliminate some of these larger issues. Because like you said, you've got these tongues that are tied, they fall back in the airway. We have this whole back to sleep campaign. I'm not speaking for or against it. I'm just saying that's what it is in the US. And when you put a baby on their back with a tongue tie that can just fall into their airway, they're going to constantly wake up. And then I've got, a lot of OTs now that I've actually met who've recently been on the podcast who believe in biological sleep, which basically is like anti-traditional cry it out sleep training. It's basically saying that you can't sleep train a child into being like a well-behaved sleeper. If the child has no medical issues, they're going to do that anyways, with some, love and direction from the parent. But it's actually dangerous for a child who has airway issues to try and sleep train them. So now you're teaching your baby who's crying and telling you, I can't breathe, or I'm waking up because maybe they just had an apneic moment. You're basically saying, oh, sorry, I'm not going to meet your needs. Like that. And I did this with Lily. Like, I actually was like almost in tears on a recent podcast with somebody, because I was like, this was me with Lily. I was like going back to work. She was 5 months old, and she was my tongue-tied baby who everyone said was fine, who was a horrible feeder and had all the symptoms. But I was that parent who went through all this. And I sleep trained her and cried. I literally sat in her room while she cried. I'm like, I can tell you she cried like for 2 hours the first night, like 90 minutes the second night, 35 minutes the third night. Like it burned into my brain. And now I'm sitting here going like, I'm lucky my child didn't die of SIDS, because she had a tongue tie, and she clearly had airway issues that were totally missed by all of her medical providers, even though I took her for evals. And at the age of 2, I took her to a couple local providers who turned her away because she wasn't breastfeeding anymore, or because, her size 3+ tonsils. Well, she's not, sick all the time. So we're just going to leave those alone. And not
You're talking about pediatricians?
2 ENTs, actually. Yeah. And then I finally took her to, an oral surgeon who said, yeah, we should address this tongue tie. That's an issue based on all the symptoms.
Well, hopefully your providers could be that missing link between the dental, medical, that world, like you could be our middleman, because there is a big disconnect between the dental medical world.
Yeah.
In terms of this stuff.
I mean, that's why I always joke. I'm like, dentists are our next pediatricians of the future. Because, when our pediatric dentists you guys are looking at things that are being turned away by a lot of pediatricians. And I do think there are more pediatricians getting on board, but they're still so few and far between. Sure. And, the number of ENTs we can count on 2 hands in the United States, it's sad. Yeah. It's great that we have the ones who do advocate and who are in this space, but everyone's like, well, who can I take my child to? And I contact another provider locally, and they're like, I was hoping you tell me you found somebody. And I'm like, no.
You're like, I just know my dentist.
I'm like, all right, go see Jen and Kim. Jen and Kim can help you.
Yeah. No, it's, the pediatrician we were at before, our current one, who knew I was a dentist, I told them I was having Gabby's lip tie released to get proper lip closure, seal, breathing through the nose. And this person's just like, why? She'll just fall and it will rip.
Oh, yeah. Yeah, we hear that one often.
Mm-hmm. They said that?
Yeah, they said, don't do it.
Do you know how common that is? There are memes about this, Kim. Like, this is like, people make reels on Instagram about this. Oh, yeah. They will say, don't worry, they'll face plant when they're a toddler and it'll just tear. Well, I actually had a patient who was really clumsy and he fell all the time and walked into walls, didn't feel anything really, like, hypo sensory wise. And he did tear it. Well, now he had a flap of skin hanging under his lip that needed to be removed. It needed to be fixed. So it's not a good solution to just,
no.
And Lily, remember I sent you a picture of Lily, Jen, she bumped her lip on our counter and actually tore a part of hers. And it didn't bleed that much, but she was like pretty traumatized from it. And this was during the pandemic. This was last year at 5 years old. So I'm like, no, not a good solution.
So speaking of releases.
Yes.
Can you talk to us about an evaluation prior to a release, to a tongue tie or lip tie release?
Yeah, so we always recommend them. It's really important to get a baseline. So we need to know what the orofacial structures look like, how they're functioning pre-op, so that it's twofold. One, sometimes we have patients who appear to be tongue-tied, and then we start working with them and we get 3 to 4 sessions in and we're like, you know what, this seems pretty pliable. It looked pretty restricted. We're kind of borderline, and these are more borderline cases. We're like, we're not really sure if we need to release them or not. You usually know if like they need to be released, like you can tell pretty quickly. But it does help for those borderline cases to get in and do some therapy. The other thing that's really important is that we are trying to see your full range of motion. What are you capable of now, so that we know what to strive for post-op?
Sure.
And also, I will add that there's 2 other pieces that I always share. So one is that you never want to teach, especially a child, some grown adults are children too, so let's just keep that in mind. You never want to introduce something new when they're healing 24 hours following a procedure, even though, in my opinion, a tongue tie release is not like a major medical procedure. It's pretty easy, and the recovery is pretty easy compared to other things out there for most people. I think that it really helps to feel really confident in what you need to do, whether it's the parent who has to get in there and do active wound care on their child and keep that because they're not getting sutured, they need to keep that healing long and strong, like I say. Or it's an older child or adult who really needs to feel confident in what they're doing, so that when they really don't feel comfortable afterwards, they're kind of like, okay, this doesn't feel so great, but at least I know I'm doing the right thing.
Yeah.
And then the other thing is too, that we've gotten really great feedback where patients are like, holy cow, I didn't realize how restricted I was, or I didn't realize what I was missing out on, or I didn't realize how good I'd feel after a full night of sleep now that my tongue can fit up in my palate and it's not glued to the floor of my mouth. Like, you don't know what you're missing out on until you experience it. So, it's really important for the medical side, but there's also the patient experience side of things that I think we need to consider too.
Yeah. And we've all 3 of us have had our tongue ties released.
Yeah, Jennifer released mine.
And then you came on my podcast the next day, right?
I know. Yeah. I didn't tell you. So she released mine on a Thursday, and on Friday morning, Hallie interviewed me. It was all, online, because it was during early COVID. And I'm not going to lie, my tongue hurt to talk. So I was like trying so hard to hide it from you, because being the terrible patient that I am, I didn't get any myotherapy. And I was like, so I was trying to hide it. And then, and of course I need to have it done again, because I didn't get therapy. It retied.
And you've done some expansion.
And I've done some expansion, a lot of expansion. But yeah, it's that first 20, I remember trying to do some exercises afterwards, and I was like, that first, I was like, not going to happen.
Yeah. Well, what's interesting? Like I always say, doctors are the worst patients, right?
They are. They are the worst patients.
There's that. But also, with Lily, I'm like, she was kind of my learning experience, because I didn't do much pre-op with her. I was just like, let's do it. Let's release. We did not suture her. She was 24 months old and she had teeth. So trying to get in her mouth, that's where I went back to like the provider that released her. And I was like, please never again release a toddler without suturing their tongue. No parent should have to go through active wound care. It's, it's one thing to get them to move their tongue around their mouth, but to actually have to go in there and elevate that tongue back and up to keep the wound healing the right direction, so it doesn't close on itself. No, not with my friend Autumn Reed Henning calls it no man's land. Like, if you're going to release a no man's land, you suture that baby up. Yeah. And honestly, I try to do it on myself. You cannot do active wound care on yourself. You really need somebody to get in there and do it on you, so that they can like do that like elevator lift, as we call it, like up and back.
And usually you do it from behind them.
Yes,
So
exactly. Exactly.
Really
it's like, it's better if you have like a dental chair, right? You could like lay down in a dental chair and someone can come up behind you and do it, or just lay down on the bed with someone behind you or something. Yeah, it does not work on yourself. I am living proof of that. So I had a little bit of reattachment too, because same reason.
Yeah, I look at it as my next diet. I'm gonna go into. You can eat right away. but you have to eat very slowly.
Oh my gosh.
And I remember
yes.
I did lose a few pounds because it was good. It showed me how fast I was eating. And I was like, I'm going to, because I really want to do this intermittent fasting. And I'm going to have Jennifer release me my first day. And it's going to make it so hard for me to eat that it'll be okay if I just do it once a day.
It's like when people start Invisalign.
Oh yeah. Oh yeah.
They're like, wait, I have to take these out to eat. Okay, no, it's too much of a pain.
It was so good in the beginning.
Oh,
It was so good in the beginning of my Invisalign. I was like, yeah, no, I don't really want to take it out just to eat that bite of food. No, we're not going to snack. Okay. I was like, this is the best diet ever. But yeah, it took me 45 minutes to eat like a half a cup of oatmeal after my tongue tie release. So I and I didn't have to chew that either.
So Hallie, you've had, I know you actually see Jennifer is your provider. And you've had multiple appliances.
Sure
So
have.
you work with a lot of patients who do the appliances. What about the timing of the release and the placement of the appliance? Like, do you feel like before someone does a growth appliance or an expansion appliance, they should be released first, after, during? Like, what's your...
It depends. It's always my favorite answer. It depends. It really does depend on the individual case. So in a perfect world, I would love for a patient to have an appliance that leaves their palate open when possible, which is not always possible based on age and other factors and dentition and everything, because then we know the tongue will have space to rest in the palate. And I personally love when we do releases like halfway through an expansion, because then we also have enough room for the tongue to now learn to live up in the palate once it's now been released. But there's always cases where, like, I've had kids who are choking on food and who just, their airway is really a concern, and we're not concerned that their tongue's going to fall back in their airway at this point. We feel like that's already happening because of, the restriction. So maybe we decide, from a medical standpoint, we feel like it's better to release his tongue first and prep them for that. And then we'll start the expansion afterwards. And, like in Lily's case, for example, she was released at 24 months. We started her ALF appliance with you, Jen, at age, like right before her 4th birthday. Yep. And then, I keep looking at her tongue. She like chokes on water when she drinks from a straw, from a straw water bottle thingy. And I'm like, why is she doing this? And so she's back in Myo right now.
Why is she drinking from a straw, or why is she...
It's like when she's drinking from like a... So when she drinks from an open cup, this doesn't happen. But when she drinks from like the thermos containers that the kids all carry around for like camp or school, like they have to have like a closed, they require a closed thing, especially during COVID. It's that like angled short straw. Mm-hmm. For some reason, she like will cough. She's not choking. She's like coughing, gagging on it frequently. And I'm like, what is going on? And we've worked on it. And so I've looked at her tongue and it looks pliable, but I'm like, I just keep wondering, is there a posterior portion of her tongue that's somehow healed to her old anatomy? And so she's had growth just by being a child, in her 4th to 5th, almost 6th year. She'll be 6 in August. And then also we expanded her. Right, in all directions. So, does she need like a touch up? Does she need a little revision for the posterior portion of her tongue? I don't know. So, I think it depends, but I always say team approach, because if we can pull in the myofunctional therapist with the dental team or, if the release provider is on the dental team or outside release provider to determine what's best for that patient, I think that's the best approach. You might need a touch up later. I always tell parents it's never a one and done. This is a journey. Like, if you're going to do this, like, get ready to go down, like, this could be a couple of years of different things going on to get the child, especially an adult, into like optimal health. Yeah, really.
So one of the things that we look at for our patients is not enough room for their tongue. Mm-hmm. And then usually there's not, when they're, at least with my patients, if they're tongue tied, there's not enough room because their mandible is going to be too small.
Right.
So then when people come and see you and they do all the therapy and their tongue is scalloped and there's not enough room for their tongue and they don't do the expansion or growth appliance, where does that leave them?
So then it's kind of like, well, is it worth even doing the release? Is it going to be able to heal into a different position in the mouth, different than where it currently is based on the restriction? Like, will we actually give you greater range of motion by releasing the tissue? Will you actually be able to swallow better? Because if your maxilla is too small and you can't make contact with your palate, with your tongue. So when we chew food and swallow, right? We chew it up and we start on like one set of molars. We chew, we move it across our tongue to the other side, chew. We do that till the food is prepped. Then we pull a ball of food. It's really lovely. It's like a mix of saliva and your food.
Is that the bolus?
The bolus, yep, onto the middle of your tongue. And we create literally a bowl with our tongue to hold the food, like the ball of food in the center of our tongue. We push that up against our palate, and then our tongue moves in this like wave-like peristaltic motion to swallow the food back. And that's where a lot of people have trouble, because their tongue, one, can't fully make contact with the palate. So the borders of the tongue, the lateral borders, are pushing against the teeth or through the teeth. And so if we can't seal off the tongue to the palate, then the tongue has to seal somehow. And that's why it pushes against the teeth, because there's spaces between our teeth. So they have to create that negative pressure. And that's where you get your tongue thrusters. So if we're just going to remain in a tongue thrust position because we can't get the tongue to seal up against the palate to swallow the food back, we look at it and we go, well, is there really even a point? You know, it's really like, what are your symptoms and how much are we going to be able to help you by doing this without really doing the full, blown treatment plan.
Yeah. So in case people don't understand, when your tongue is tied down, because your tongue is made up of, your traps and your pecs, all these 8 muscles are very strong, and your tongue's being held down and it can't really move in the directions it needs to move. It keeps your mandible from growing forward. And then what happens is you can't get a lot of air, past your tongue, to breathe, because your tongue is being held in the way. So what happens is the roof of your mouth grows up and it becomes very vaulted like this. It should be almost flat, but it grows vaulted, and it becomes this vaulted ceiling that you can't put your tongue up on the roof of.
Because you physically can't get your tongue there. Yeah. It's tied. And
it's just it's a lot of these patients are too narrow too. So you just can't get the sides of the tongue to sit inside,
Yeah, your body did that so that it could get air. It's kind of interesting. But so then the whole idea is that we grow you out and like that. But then if the tongue is still being held there, if they can't move their tongue,
right,
we don't get the results.
Yeah, that's why it's very important to treat as a team.
Yeah,
hence the team approach to treatment about the tongue position, tongue swallowing, all that.
Well, I think people get like really fascinated by like the CBCTs. So I just shared my before and after on Instagram, like about a week ago, and people were like, holy cow, because like you can see color, right? Like if you're not colorblind, you can see the difference between like, the size of my airway before because I had a DNA appliance with you. So kind of going back to your question that I never answered. So first I had my DNA appliance with you, and even backing up further as a teen, a young teen, like around 12, 13, I had rapid palatal expander, I had braces, and then I had, I don't know if at that point they put in the permanent retainers, the lingual bars, but I had both upper and lower permanent lingual bars. And they said, oh, this will fall out by the time you're 20. So I thought like, okay, I'll have it for like 7 years. At the age of 30, I was like, can you please take these out of my mouth? Because it's really hard to clean. And I'm constantly having to go back to the dentist more frequently just because of the buildup under the lower lingual bar. And so anyways, they took it off, and then my teeth started to shift. And I was like, why are my teeth shifting when I've literally had something holding them in place for, 15 years more at that point? And I realized I was a tongue thruster. My tongue was laying low and forward. I had a tongue tie. My palate, my teeth looked beautiful on top, and they were, they were white, they were straight, they look great. And my husband's like, I married you because you're a good horse. Like, you have good teeth. Like, that's what he says to me. He's like, now you're going to go mess them all up. I was like, it's for my health, honey. So we went into the DNA appliance, and the DNA appliance was amazing. I think with like 3 millimeters of growth, both like forward and laterally, like my airway is in a much healthier position now. Like my tongue fits up there. I did have my tongue tie released before expansion. But it's been really incredible to see the difference between like traditional ortho, like having gone through that as a teen, and now what we were able to do with me as, in my mid 30s. So I think that's pretty cool. So thank you for that.
Yeah, no, I sometimes like feel bad. Like for example, for myself and like one of my sisters, we like undid that traditional ortho.
Right.
Like, sorry, Mom and Dad, you spent all this money. We're just undoing all of it. And then, because unfortunately, like we've talked about before, about the retraction orthodontics,
yes,
just putting everything on and retracting everything back. And when you do that and you bring the jaws back as opposed to allowing them to grow forward and out, it impinges on what's behind your jaws, your airway.
Yeah.
And then, unfortunately, like you already talked about, with like, you go to sleep just due to gravity alone, tongue falls back into the throat, especially when it's like tied and it can't get to the tongue. It can't get to the top or the roof. You know, it's just everything's in the back of your throat. And then the body's like, oh no, can't breathe. Let me clench and grind to get the tongue out of your airway. And then, yeah.
So you guys do a lot of cases together.
We do.
Anything stand out? Any good and bad?
Yeah.
I mean, so let's talk about a good one. So we had a kiddo who was playing sports and wanted a removable appliance. I don't know if you'll know who this was. And this was just like an A+ mom, like amazing kid, amazing mother. And he wanted the DNA appliance because he could take it out to play sports. And I'm telling you, I've never seen like a case move so quickly through Myo. Like his expansion was phenomenal. Like how old? I don't remember how 12. Old he was. 12. Okay. Yeah. And so it was incredible to see just when you really just need traditional Myo and expansion, how fast, I don't know.
And then his speech improved.
Yeah, his speech improved too, which is why mom came to me in the first place.
Was about speech.
Was his speech. And I was like, hold up. We're not going traditional speech. We'll work on that if we need to. We never had to address the speech. It was pretty cool. And he was a kid where it just was like boom, boom, boom. And I was like,
and with that being said, we do have athletes that do the fixed appliances as well, like the ALF. It just depends on, it's all patient-based care. It's all patient-centered care. What does the patient want? Because we're good about showing the patient models. And for a 12-year-old, they're fully capable of helping aid in that decision, you know? But you do have some that, you know, some kids... Compliance is an issue. So they're going with something that the parents don't have to worry about at home, that the kids don't have to worry about, which is the ALF that stays in. And you just have to be really good about brushing and flossing, which you should be doing anyways.
And I think something too that's important to point out is that a lot of these patients have anxiety because of their sleep disorder breathing. And so if we're like already dealing with a population that may have like heightened anxiety, to put like something in a kid's mouth that they're going to feel more anxious about. Like, I think it's really awesome that you guys take this patient-centered care approach, because for him, it was like critical that this come out when he played sports. And he didn't have to come out because he was playing sports, but for him, that was important. Yeah. And so you were like, okay, we can work with that. And look how fast he moved. Yeah. Like, just totally incredible. Yeah. So that was pretty awesome.
That's so interesting because my adult patients who play like a lot of Division I sports and stuff actually come in and get the appliances to wear while they're playing the sports because they play better.
Because it helps their mandible. Does it bring the mandible forward so they can breathe better?
It puts them in neutral. So especially baseball players,
Interesting.
They can throw straighter, they can throw farther, hit better. They panic, as a matter of fact, when they break it or lose it. You've seen some of these patients. I have patients who are traveling like, I have this big game in I put it in my back pocket.
Well, why did you do that?
Yeah, I know. That's why I just, like we've been saying with the patient, because like for a 22-year-old, it's such a mental, you know, versus this 12-year-old who's like, it's a mental game too, but he was mentally in the other sense, like, I don't want anything in there, you know, but like.
And I think too, like at a certain age, you're kind of like, I don't really care what everybody thinks about me. Whereas like when you're dealing with like a young, like a coming to teenage, it's kind of like, well, I don't want people seeing me wearing something that other people aren't wearing. So I feel like there's so many different factors that we have to like take into consideration.
Like as an adult, everybody wants to wear Invisalign or whatever. So it's like this cool thing. But when you're a kid, maybe not.
I can't talk with it in, so I have to take mine out. So mine's out right now, but I'm also in my last month. So
you also, you've come a long way. It's incredible.
Yeah, it's been amazing.
Like, done having something in your mouth.
I know. My husband's like, so when is this going to be done? Are you gonna?
You're like, it's a journey. 5 years, honey. You know?
Well, we put him in an ALF, but we won't talk about him because he's like a child. So
he's doing great.
Glad
you're doing great.
We can talk about that for a moment. It's okay. No, it's one of those things where he has the ALF, so it's in there. People can't see it because that was important to him because he's on a lot of Zoom calls and he's an attorney and, you know, and doesn't want it to impact his speech and all that stuff. But then like things get stuck and he's like, I hate this thing. I'm done with this. And I'm like, okay, fine. Just, you know, take it out of your mouth. But you paid all this money for it. I'm not just going to throw it away. I'm like, okay, you do you. Whatever. I don't care what you do anymore. If you want something different, we'll get you something different. Yeah, no, it's a journey for sure. But when you, like I said, I think earlier when we were talking about how patients don't realize what they're missing out on until they've gone through that experience, it may take you a couple years, it may take you 3 years, 5 years, I don't know, but it's completely worth it in the end for the change of, life that you get out of it.
And sometimes the patient themselves, they don't even realize.
Oh no.
I feel like a lot of times it's the family members. Like we have children that are 10 years old that are still wetting the bed. That's a sign of the sleep disorder breathing. And I had a mom, and it's just, because from one of the other podcasts I listened to with Dr. Kendall, Larry.
Lenny Kundal.
Lenny Kundal. He was saying, these appliances can sometimes be difficult, but at the end of the day, they're so good for the individual. And it's definitely a change. Having something in your mouth, it is a change, but we actually have a family member that's going through appliance therapy right now. And they're like, look, I noticed the changes. It's great. But it's like all the people around in the family that are just like, oh, this person's not doing this anymore. Like the nervous tic has subsided. Like all these things have gone away. And they're just like, this person's just so relaxing to be around now. And just that you really take away that like fight or flight.
Yes.
Yeah. They do help put you in parasympathetic mode.
Yeah. It's very cool.
It is.
And then I think also people don't realize that even just with myo and definitely with the appliances, that also changes the aesthetics. It changes the way you look, your profile.
I got cheekbones.
Yeah.
There you go.
I was like, when my cheekbones popped out and I no longer had to make up them on, I was like, Jen, look, her cheekbones.
You're like, the air's flowing through my sinuses.
I was like, the DNA appliance worked. Yeah. But I think the other thing that we should mention that hasn't come up either was body work. Like for me, that was critical. I realized like halfway through my expansion process that I could no longer crank my DNA appliance unless I saw Manny, who is in your office. And, and I would go to him even between my appointments with you all, because I noticed that I could just breathe so much better. Things were flowing the right way. It's like, I don't even know how to explain the right way, like what he does.
Kim, how do you describe Manny, Kim?
I call him Yoda.
He's the body Yoda.
Yeah. Yep.
He finds points of restriction. He uses the counter strain technique and just finds areas that may be needing a little bit, release while we're doing the growth appliances.
It's incredible.
Or whatever.
Yeah, it's incredible.
So we have a secret question to ask you.
Oh, a secret question.
Yeah.
Bring it.
Yeah. So if you could pinpoint or identify 2 celebrities that potentially have airway issues, tongue ties, so many.
Pick your 2 favorite.
Yeah.
Like the most
Okay,
obvious.
now I'm horrible with remembering names. Grey's Anatomy, Meredith Grey. What is her actual name in real life?
Well, let's just say Meredith from Grey's Anatomy.
Okay, fine. So Meredith from Grey's Anatomy. There is a photo circulating right now of like her crying from one of the episodes, and you can see her tongue restriction. Like you can see her tongue tied down to the floor of her mouth because the tip of her tongue does not elevate at all when she's crying. Her whole entire face is like, and then the tongue is like scooped like an infant tongue tie. It's incredible. Like I will send this to you guys later.
Yeah.
And she also has, which is very typical, because she's so small here, she's got that wrinkling right here. I've noticed that before too.
Yeah.
She needs
around the orbicularis oris, and then the mentalis is all bunched. Yeah, she's very tight.
she's beautiful, but
She is. Well, and that's what's so interesting, right? You see these professionals who have these fantastic careers and they've gotten so far, and then you look and you're like, holy cow, OMD, there's this major orofacial myofunctional disorder going on here.
But as they age, it will become a problem.
Yeah.
It'll be a lot of plastic surgery.
Yeah. Well, here's another interesting one that just popped into my mind. Michael Phelps. So swimmers tend to jut their jaws out of alignment to maximize staying underwater longer. Basically that's a layman's way of how it's been explained to me. So he's got that long, narrow profile. And yes, he's tall, but he also has like a long, narrow profile. His mandible sits forward. He's a mess.
Yeah. And some people, when I was doing my ALF residency, they would talk about Phelps as an example that he chose a sport where you could do open mouth.
Yeah.
Versus like when you're running, you try to
breathe through your nose.
Breathe through your nose as much as you
Usually.
can, right? Until
Yeah.
you can't. Yeah.
Yeah, ideally.
Ideally, yeah.
Yeah. So it's interesting. And I have heard that he actually is like attending to it now, that like he actually is getting treated like through the grapevine. I don't know how true that is or not.
You could see pictures of him in his dental crowding.
Oh yeah.
Yeah. But then I feel like some of these people worry that if they like change, like Phelps, he's like this huge athlete, obviously. If he changes that, will his performance change?
I think he'd be better.
Of course.
Yeah. I don't know.
Again, mental game.
It's so interesting. But yeah, there's actually a Facebook group where a whole bunch of myofunctional therapists pulled together, and they just would post like picture after picture of like professional actress and athlete and all these people with myo disorders. And they were like, what do you see on this face? And I'm like, you guys have way too much time on your hands. But it is interesting.
Thank you so much, Hallie Bulkin. This has been amazing.
Yeah, Hallie, and we have a gift for you.
Yeah. Oh. So cute. I love it.
Vigilantes.
I love it.
Thank you.